All right, good morning, folks, and welcome to the Palliative Care Friday Chalk Talks. Today's discussion is on cardiopulmonary resuscitation and all the good and the bad and ugly things that come with that. So our speaker today is the fabulous Dr. Saman Misbah, who is a hospice and palliative care fellow with us here at Advocate Aurora in Milwaukee, Wisconsin. And our format today will be a presentation followed by an opportunity for some questions from the audience. So sit back, relax, and enjoy. And Saman, the floor is all yours.
Thank you, Dr. Basilic. Thank you for the opportunity to present today. It's also the last Chalk Talk, I think, before the winter break. So that's exciting. I wanted to, end us on a lighter note, talk about something that we see as palliative care physicians, we see and talk to our patients about quite a bit. Just thought we would just go back and look at some of the history of CPR and see where we're getting some of the information that we give our patients. We really can't talk about CPR without talking about cardiac arrest. So we'll talk about the definitions and different types of cardiac arrests. We will also touch base on the history of CPR. We will talk about injuries associated with CPR, and this will sort of bleed into our last slide, which is CPR and palliative care. All throughout the presentation, we'll talk about some statistics that are associated with cardiopulmonary arrest and cardiac arrest, resuscitation and arrest. So there's that. Let's go right into the next slide. So cardiac arrest. By definition, cardiac arrest is the absence of palpable pulse, and usually it has heterogeneous causes and outcomes. Typically, the way we define cardiac arrest is based on either location of the event or the presentation. The location meaning, is it in-hospital cardiac arrest or out-of-hospital cardiac arrest? And presentation meaning whether it's shockable or non-shockable. Nearly all of our high-quality data about the epidemiology of in-house cardiac arrest comes from quality improvement registries, such as the American Heart Association's Get With Resuscitation Guidelines, the Swedish CPR registry, there's like a Danish registry and a British registry as well. In the US, we have an estimated of 292,000 cases of in-house cardiac arrest in adults every year. The pediatric number is about 15,200. And then just to put that into perspective, that's an average incidence rate of 10.16 per 1,000 hospital admissions. If we look at a similar period of time, the out-of-hospital cardiac arrest is about 347,000. Throughout this presentation, I will be focusing more on in-hospital cardiac arrest, just because that's where we have majority of our data. And then we've had published observational studies that talk about the causes and then the outcomes of in-hospital cardiac arrest. One of the biggest identified cause has always been hypoxia, and then followed by acute coronary syndrome, arrhythmia, hypovolemia, and infection. In about 69.8% of the cases, the presenting rhythm was shockable. The outcomes, much like the cause of in-house cardiac arrests, are very varied. Based on an analysis of the Get With Resuscitation data from 2018, 25.8% of the patients suffering in-house cardiac arrest survived to hospital discharge, which is not as great a number as we would hope, but it's there. It's better than 0%. And then the further analysis also showed that 54.2% of the events occurred in an ICU, OR, or ED setting. They did note that in-house cardiac arrest in the OR or cath lab is associated with a slightly higher increased survival rate at 38.1%. And I think that has mostly to do with the nature of, it's probably either an iatrogenic cause or just the location allows for quicker response time. The other thing that they've also noted is that duration of the resuscitative effect of the effort is associated with survival. So in this case, the shorter the effort, the more chances of survival. So I think the stats is about 62% 30-day survival if the CPR effort was less than 5%, versus 8.1% if it was greater than 20 minutes. So overall, we've got some statistics about what happens immediately post a cardiac arrest. We do not have very good functional outcomes over a longer period. There is some newer studies over there in that area, and we'll talk about it a little bit later, about some of the papers that I found during my research. But there is recent newer data is showing that we may have a favorable outcome for patients, majority of the patients who survive to hospital discharge, which is 25%. Based on the earlier statistics. So with all that in mind, let us go and look at this ACLS algorithm, the one that we know and love so much. It is very streamlined, it's easy to follow, and the American Heart Association has done a great job with it. But before we came to this version of the ACLS algorithm, we had there were a few hiccups around along the way. We've known CPR techniques to be used all the way back to the 15th century. A Swiss physician would use the bellows method, which was they used a bellow to blow air into the mouths of the patients to try and get them to take a breath again. So that was one of the earliest iteration of mouth-to-mouth resuscitation, actually. Then we had the first instance of a science-based organization recommending mouth-to-mouth resuscitation was in 1740, when the Paris Academy of Sciences recommended it for drowning victims. Over the next few centuries, the 18th and 19th, science did improve on chest compression as well. They initially started with placing pressure on the thorax, and then they used this chest pressure arm lift method, and then finally arrived to the closed chest compressions that we use now. In the mid-20th century, we had Dr. James Elam, who found expired air to be sufficient to maintain adequate oxygenation. And then Dr. William Covenhaven described external defibrillation in 1957. So putting all of this together in 1960, Doctors Covenhaven, James, and Safar were the ones who combined rescuer closed chest cardiac massage with mouth-to-mouth ventilation into what resembles current CPR. And the same year, in 1960, the American Heart Association started educating physicians in the technique of closed chest resuscitation. In 1975, the first ACLS textbook was also published. And in 1992, the International Liaison Committee on Resuscitation was formed. Since the 15th century, the science behind CPR has improved significantly. And the American Heart Association, the ILCOR, and the European Resuscitation Council, they usually release joint guidelines and updates and recommendations on which are designed to be more effective, practical, and simple. However, despite all the strides that we've made, the focus with CPR has always been the same. The point is to restore circulation and identify and correct the underlying etiology. And it sounds like a simple process, but it's not, because cardiac arrest is a dynamic process. It requires team-based care and multiple systems working together to optimize patient outcomes. And while we have good data about how effective it is, there are some side effects, if you will, to it. So this slide and the next slide, we'll talk a little bit about that. So closed chest compressions, the effective closed chest compression is the cornerstone of CPR. It's always been. Every single guideline will talk about good quality manual chest compressions, and decompressions. So every time we put pressure on somebody's chest, we may be causing some injuries. So I wanted to look into the incidence of these injuries and see if there's ever been a literature search about it. And I found this one paper, actually, which was a case study about atrial rupture associated with manual CPR. And they also, the good thing was these authors also did a systemic review with pooled data analysis of CPR-induced injuries. And they looked up 928 relevant studies and found incidents of major cardiac and large vessel injuries in them. Though some of the statistics associated with it that I found were about 8.9% of the cases had pericardial injury and hemopericardium. And then 7.5% of CPR patients had hemopericardium. There were also some pulmonary complications with aspiration of gastric contents leading at 10.9% of the cases. There was also pneumothoraces and hemothoraxes at about 2%. The other, which is this really hard to see table, talks about fractures, which was actually the leading complication of CPR that I found at 31.2% of patients who underwent CPR came out with associated rib fractures. Another thing to note was flail chest has been reported to occur at a rate of 5.6 per 100 survivors of CPR, so not unsubstantial. These are just the physical issues with CPR. There are some psychological issues that come to post-CPR. Studies have already shown that anytime we have prolonged hospital stay, which is what most of these patients who've had cardiac arrest in the hospital will be experiencing, they're associated with mental health issues. PTSD, major depressive disorder, and anxiety are a few that arise. There was a study done in Amsterdam which evaluated post-cardiac arrest patients who've been discharged from the hospital for a little bit of time. And then they did find out that the quality of life is poor in survivors after resuscitation compared with the control group of older adults who didn't have any resuscitation efforts done on them. But one of the main things that I did see in the papers is that there is no set consistent protocols for follow-up in facilities for patients who are post-cardiac arrest. So many times we might see these patients outpatient, or the primary care physicians might see them outpatient in clinics, and there are no set guidelines on what to look for, what to screen for in these patients, which makes it difficult for us to know what to expect for them, even 2 years down the line, 5 years, 10 years down the line. So with this, I kind of wanted to segue into CPR and palliative care, because CPR is an integral part of dying in the hospital in the United States. In fact, it's one of those procedures that you need for a patient to opt out of it. They need to either provide special instructions or sign paperwork saying that they're opting out of it. But however, when we initially started CPR, when it was initially when Copenhagen described it, it was meant for use in healthy patients for management of a sudden cardiac arrest, which is reversible and caused by specific causes like complete heart block, electric shock, drowning, etc. It's meant to treat an acute insult. However, now the norm is to attempt CPR on any dying or dead patient, regardless of underlying cause. So we have these complex patients that we see as palliative care physicians who have either, organ failure of some kind, major organ failure, or multiple organ failures in the hospital settings, or they have cancer. And we are going ahead and asking them whether they want to be resuscitated, as in brought, and many patients will say, yes, do everything. But then the question is, when the statistics are already so poor for patients who don't have these big giant issues, are we doing our patients a disservice by providing them this as an option? It's a controversial thing. And then the paper I was looking at was from the American Journal of Palliative Medicine. It's a few years old, but that's what the authors were asking. We decline procedures and treatments for patients all the time because we don't think they'll survive it, or it'll cause undue stress. Is CPR one of those procedures as well? And is there something that we need to do? Do we, is it right for us to offer it to people all the time? And that's where I kind of wanted to open the floor up for discussion and see what others thought about it.
All right. Thank you, Simon.
Thank you.
We will open it up for questions. I would say if you have a question, commentary, anything, you can either use the raise hand function, you can throw something in the chat, I'll call on you. If you're brave enough, you can even just unmute and simply speak. That sounds great. It's interesting that is your opening question, and I'm going to ask you one to give people a moment to think about their own thoughts, because that was exactly what I was going to ask you about, because we have data that shows that there are certain subpopulations that have extraordinarily low survival rates. There's some data that metastatic cancer patients in the ICU that get CPR have low single digits, that they just survive. That's not meaning they leave with good functional status. They just leave the hospital with a heartbeat. And there are other populations too. I think there was an outpatient study on octogenarians and older, again, low single digits, sometimes even less than single digits for survival. And at what point is that number so low that you wouldn't offer somebody the chance to pick? And I think it depends upon when you trained, where you trained, how old you are, what level of paternalism is just part of your natural ability, how much emphasis do you put on autonomy, what you think a role of a physician should be. And I don't know that there is exactly a right answer, but I will ask you, Simon, in your own personal opinion, what is too low? Would you ever not offer the option, which has no right or wrong answer, just what is your opinion about that?
So I think my opinion is starting to change a little bit. I was a hospitalist before I came into fellowship. And I think when doing my family medicine residency and during my tenure as a hospitalist, if you ask me that question, I would say, oh, it's not up to me. It's up to the patient, 100%. Because, I want to offer everything I have to them and go ahead and they make the choice. But now, 6 months into fellowship, I've seen firsthand how much patients value the guidance of their physicians, especially ones that they've maintained some sort of relationship with and they've established some sort of relationship with. So in that case, I think I would be giving an opinion to them. It is still their choice, but my opinion is such and such.
Okay, so I hear you saying there's no absolute cutoff for which you would not offer and take away the option of choice. Still would offer choice, but certainly involve your opinion on what it is that they would want. I think it's very interesting. Yeah. Tell me a little bit more about this breaking ribs, and because I said, when I trained, I was taught not to talk about breaking ribs, and I'm not saying it's right or it's wrong. It's just that is the flavor of what I was taught. And sort of what was pitched to me was, if you lead with that, you're trying to sort of coerce, you're trying to scare them, or maybe you're actually projecting your own personal fears onto your patients. What's your take on involving things like talking to patients about broken ribs and the horrors that come with CPR? the collateral damage?
So I've personally, I think I mentioned this before, I've had quite a bit of success, which I don't know if I scared people into choosing DNR, but I've had quite a bit of success with the specific breaking ribs aspect. And I don't bring it up for every single patient. It's mostly patients that I'm worried about based on their, their BMI or just like their age, that I think that if you suffer a broken rib, that's going to be worse for you. Your quality of life is going to go down significantly. And there is a chance that you might not improve from it at all. So rather than suffering through all that pain after a whole resuscitation effort, perhaps we just bring that concern up front, and then see what they say and how they feel about it.
Right. We do have a question. Actually, somebody sitting in the room with me. We'll swap spots so you can ask.
Oh, nice.
How's it going, everybody? Tim, one of the new docs here at St. Luke's. Not so much a question, somewhat of an opinion, just my take on it. And I just finished fellowship last year.
Mm-hmm.
So when I approach this with patients, I approach it as a procedure.
Mm-hmm.
And is it beneficial or not to the patients? I have no problem with a patient wanting to die, having CPR done to them as a last resort.
Mm-hmm.
So when someone is really against it, or really wants it, I mean, at the end of the day, we do it all the time. The only time I ever have had a problem with it is during COVID. I was a resident and I did compressions on patients that was not going to make it, and potentially put everybody else at risk. And so really that's my only caveat I have in myself of not, when I would not do it. But at the end of the day, if someone wants it done, I think that's their choice.
Mm-hmm.
And then I just approach it as a procedure. And then I know there's a little paternalism within that kind of framework. But at the end of the day, I don't force it on them, and I kind of let them decide. And the broken ribs one, for me, I try not to use it because it's a little bit brutal imagery. But the option is they're dead anyways. So that's kind of where my take comes in with that, where if it'd be worse off if we don't, do it and break your ribs. Well, I mean, the worse off is you just wouldn't be here anymore. So that's just my 2 cents on it.
Yeah, no, thank you, Dr. Swartz. Appreciate it. And yeah, you brought up the interesting point about COVID and CPR, because CPR typically is not the providers doing it. It doesn't cause too much harm to them. There's always time, and then there's like monetary resources that are put into CPR. But COVID was one of those instances, or just any infectious etiologies. There's an instance where it might affect the person doing the chest compressions, or they're trying to intubate the person. So there's that too. There's this occupational hazard aspect to it too. That's interesting. I didn't think about it, and I didn't find much of that in my research, but COVID's pretty new, and I'm sure in the next couple of years we'll start seeing papers about it too.
Scott, thank you for the question in the chat. Could I ask you to unmute and share that out loud for us?
Sure. One of the things that I've noticed is that, well, first and foremost, we're kind of, I don't mean to be snarky, but we are preaching to the choir, so everyone here understands what the risks are. I think when we go outside of this, the challenge is working with our respective team members on having effective code status discussions. Sometimes I see some challenges in just giving ourselves the permission to state it's not our recommendation to pursue CPR. They leave it's left often too vague and open for the families to decide and the patients decide. One approach that I tend to take is that CPR is something we attempt to do to reverse death, not to save someone's life, because everything we're doing is, once the heart stops, that's when we die, and we are racing against the clock to reverse their death. Mm-hmm. We can cause a lot of damage to the chest as we do it. And then I often end with, would you want us to allow you to rest in peace when your heart stops and you die, or do everything we can to try to reverse that death, even though we likely won't be successful and we would cause a lot of injury to that person? One thing I'd like to know, and I don't know if anyone has any data on this, is just the study on moral injury for people who have attempted CPR. So ER workers, trauma physicians, trauma nurse practitioners, ICU workers, what is their experience as they attempt it? How has it changed throughout their careers? That would be sort of an interesting study on moral injury, if that someone wants to do a deep dive into that.
Yeah, it's a really good topic to talk about. I didn't come across anything that specifically addressed the healthcare workers doing the CPR, but yeah, that'll be very interesting to know.
Just related to that, the moral injury. I feel like when I am being asked to come in and frankly get the DNR or whatever the consult is for, I think oftentimes what I'm really doing is helping with the moral injury, exactly what you brought up. I think when we dig deeper, what we really reveal is that either bedside staff or primary team is really concerned that we are torturing their patients or causing suffering that this person would not want. And so oftentimes I think our role is to provide this patient a voice to relieve some of that moral suffering so the bedside staff can appreciate why it is they want instead of assuming something that they feel, which may or may not end up being accurate. Lindsay, I see your hand is raised. I think we will let you be our final question for the day.
All right. I'm sorry if we don't have time. I'm going to try and make this brief. I appreciate, all the perspectives and everything that was said. I, am in full agreement, but I am going to push back a little bit and play devil's advocate here.
Good.
About telling people that we're reversing death. Because I think this is a tricky subject here. And, I think we all agree that when the heart stops beating, I won't say I think we all agree. I think it's a tricky topic about when a person has died and if we're truly reviving them from death, because that gets into a whole nother area versus we're saying someone who's in cardiac arrest is moving in a direction of dying and we're trying to restore their organ function. Versus they have already died and we're trying to revive them. I think that could be a whole nother chalk talk and topic of interest because it's just almost too much to talk about here. But I think if we had more time, I would be curious on others' thoughts on where we can use that point of death and reviving someone from death.
Thank you. That's a good way to think about it too. I don't think I have before.
And I just want to add, it may appear that we're preaching to the choir, we're all on the same page. I don't actually think that's accurate. I think there's quite a bit of variability within the palliative care field. And I think it depends upon where you practice and where you're embedded. I could imagine that there are palliative care teams within the ICU, embedded within ICUs, that maybe are a bit more along the line of critical care providers that may set some limits, that may not offer some choices, that may be a little bit more paternalistic. I think there's more variation there than we think. I think some, maybe most palliative care clinicians want to help affirm the values of a patient, but I think there are just as many palliative care clinicians that are thinking, and what is also in the best interest of my colleagues? And I think there's some debate there about where you're at and supporting them and helping set some limits. All right. Well, we are just about at time, Saman. We appreciate you. Appreciate you sharing.
Thank you so much.
Absolutely. All right, everybody. Have a wonderful Friday.
Happy holidays.
Happy holidays. Bye.
Bye.